So let's start with our first speaker, Professor Tom Shakespeare from the London School of Hygiene and Tropical Medicine. What a researcher, what a man. Everybody wants him to speak at their conferences, and I have unashamedly played the friendship card to get him to speak at ours. So I think if you're not already aware of Tom's work, I think you'll find this talk really interesting. Tom's hugely prolific in the area of disability studies, one of these people with an astronomical H index, but also very broad reach. So he's on BBC Radio, he's on Twitter, and he writes books. Here's one from 2018, Disability, the Basics, 150 pages, so you can definitely get through it. It's not just for people with disabilities, it's not just for disability researchers, it's for everybody. So do yourself a favour and have a look at that. And in the meantime, we'll flip over to the pre-recorded talk, and he's actually already anticipated and answered questions in his talk. So thanks very much to Tom for being part of our conference.
How independent are you? When you think about it, we're all dependent in some way. If the tram driver doesn't turn up for work, or the caretaker doesn't open the door, or there's a power cut or a fire, then we all grind to a halt. In the Western world, we are culpable in the promotion of an ideal of independence, but in reality, it's a fiction. We are all dependent on a vast and usually invisible web of services and suppliers to deliver our petrol and our milk and our mail and our internet access and everything else we take for granted. When there's a pandemic or natural disaster or industrial action, we suddenly realise we cannot manage on our own. Even without such crises, many people rely on the hidden labour of others, often women, to make our meals and clean our homes and care for our children. In my view, we would be better thinking in terms of interdependence rather than independence, because it helps break down the distinction between disabled people and everyone else. It's not that some are dependent and others are not. It's that some forms of dependency are visible and others are invisible. Some are stigmatized and others are acceptable. Relying on a mobile phone is fine. Relying on a hearing aid is discrediting. We were all once dependent as infants, and we will likely be dependent again in old age, and we're dependent if we damage our shoulder, and we're dependent if we have coronavirus. Dependency, says my friend Jackie Leach-Scully, is not just a difficult fact of life, it's part of what makes us human. In an Anglo-Saxon context, we favour independence and individualism. But it's important to note that in many African countries, and Asian countries too, and in many Aboriginal and Indigenous contexts also, interdependence, family relations, community are more important than separateness and individualism. The feminist ethic of care also emphasises relationships and interdependence more than rights and individualism. It's not just that the highest level of ethical reasoning is abstract individualism. That is a very male, traditional way of seeing things. Remember writers such as Eva Feder-Kittay and Joan Tronto. Eva talks about how the theory of justice of John Rawls takes no account of the fact that some people are disabled and others are supporting them. It assumes we are all individual competitors in a neoliberal marketplace. We need to have political philosophies which take into account care and relationships because they are central to human existence. They give value to human existence. In everyday life, in everyday relationships, dependency is mitigated by reciprocity, that unspoken expectation. If you feed my cat while I'm on holiday, I will bring you back some duty-free from wherever I've been to. If you look after my kids this weekend, I will look after yours next weekend. More complicated versions of this principle involve paying it forward. This family brought me meals when I was laid up in bed, so when another friend is convalescing from her cancer, I will in turn bring her meals. As long as this is well understood between all parties, the relationships work out. None of us feel inferior. But without reciprocity, you have uncomfortable dependency, which is sometimes called charity. If the neighbours are always doing things for me and I do not do anything for them in return, I begin to feel awkward about asking them. Maybe even they start resenting me, taking them for granted. Or maybe they're perfectly happy about it. They feel charitable towards me because they feel sorry for poor, inferior, unfortunate me. But now their goodwill puts me down. The favour that I cannot reciprocate makes me feel dependent. In 2008, when I developed spinal cord injury and ended up in a wheelchair, since then I realised that not everyone is equally interdependent. Some people are more dependent than others. I have restricted growth, and before I was paralysed, about the only thing I couldn't change was the light bulb. It's true that changing the duvet cover is pretty difficult, but I managed it after a bit of bother. If things were too high, I'd climb on a stepladder to reach them. Now I need help lots of the time. Sometimes I need help to get on and off trains and buses. And it's different whether it's a paid helper, where I expect it, or a member of the public, where I say thank you, thank you, thank you. At home, I can't really do the hoovering or get things down from the shelves, so my cleaner's coming around later today. I might knock on Paul's door and say, Paul, can you get down the dryer hose because I can't reach it? I can still do the shopping and cooking, but making the bed is really tough. And this is normal. Most disabled and older people who require help rely on care from family members or private care agencies. And it makes a big difference whether I ask Paul to help me or I pay my cleaner, where I am friendly, but I don't need to feel obliged. Whereas Paul, I have to be friendly with. I like him, it's fine, but I give him a glass of wine from time to time. But clearly I'm struggling for reciprocity. Delivering care, if you do it all the time, is a tiring and difficult business, whether or not it's paid. Emotional work, and notice that phrase, attending to someone else is a form of labour, like cleaning. Care is undervalued and very poorly paid in our society. And it's also difficult to receive care on a daily basis. Temporary bouts of incapacity, like an illness or a sports injury, are one thing, but a permanent, ongoing need for help is different because it begins to affect identity. I don't think people understand this unless they've experienced it firsthand, so let me explain. The first problem is you can't do the thing you need help for. That's frustrating. The second problem is that you have to ask someone else for help, a paid carer or a partner or a friend, which often feels demeaning. The third problem is that you have to receive the help, which may well not be given in the right way, which is frustrating. And the final problem is you have to be grateful, even when it's not quite what you needed, which means pretending to feel something which you don't. And also, because the paradigm model of care is parenting, we can't seem to avoid infantilizing people to whom we provide support. We talk to them and about them as if they were children. Think of how we talk about older people. People who receive care can quite easily slip into passive dependent roles. I can't do anything. Care may be benign or it might be absolute. Care might be benign or it may be abusive. But even when it's proper, kind, considerate care, it leaves the recipient in a devalued state because they cannot reciprocate enough. Tolstoy once wrote, quote, "I sit on a man's back, choking him and making him carry me, and yet assure myself and everybody else that I'm very sorry for him and wish to ease his lot by all possible means, except by getting off his back." But there's an alternative. Since the 1970s, people with significant impairments have emerged from residential institutions to live in the mainstream. And this independent living, as we call it, was a revolution in human history. For centuries, people who had high levels of physical dependency had three options. Either they died, which they did in very large numbers, or they lived at home and were looked after by family members, or they lived in institutions. The innovation in human relations that enable people with significant impairments to live independently or interdependently in the community was called personal assistance. Instead of relying on carers, they were given money to employ their own workers. And remember, money, i.e. paying my cleaner, means I don't have to be grateful in the same way as I do when it's Paul next door who helps me. With direct payment, as this system is called, came liberation, because you have reciprocity. The disabled person had to recruit, train and manage people. In turn, the worker is dependent for their wages on the disabled person. Reciprocity is restored. You, the worker, act as my arms and legs, and I, the disabled person, treats you with respect and pays your wages. It's a contractual exchange. People can dictate how they want to be supported. No wonder this model is used by tens of thousands of disabled people and is developed into personal budgets, and I think it's relevant to the NDIS scheme. The disabled activists who pioneered personal assistance believed it would also separate tasks from emotions. They could buy someone else's time to do the tasks, much like paying a stranger to mow your lawn, without having to be grateful. But as soon as you have two people working together, you have an emotional relationship. It could be a good relationship, which helps both parties, or a toxic one, in which people are miserable. So we did a study of personal assistant relationships, lots of interviews, both with disabled people and people who they paid to work for them. And it brought together psychology, ethics, and sociology, roles, power, and obligations. It was all there. But what we found is for most of the time, the relationship goes well. Both sides love flexibility and informality, and the personal assistance empowers disabled people who feel in control. But everybody had experienced conflict in PA relationships, partly because it moved from its original days in activism to just everybody with disability who might be unfamiliar with the sort of ethic of independent living. But human beings are complicated, and this is a relationship between human beings, so problems occur. The disabled person falls in love with their assistant, or the worker steals from their employers. One person wants to go and see 50 Shades of Grey, but his assistant says it's violent and exploitative and doesn't want to go. And these problems could be personal, practical, or about proximity. They can mostly be solved. For example, a good recruitment process and a trial period can solve the personal clashes that might otherwise occur. A clear contract and a list of tasks to be done helps with practical problems. Communication is the basis of good relations. And of course, proximity is a less of a difficulty. If the PA has her own space, if there's time away between the PA and the disabled person, they're not always together, or maybe the disabled person has a rota of personal assistance, not the same person every day. Personal assistance still involves dependency, even if it's less overt. The worker depends on the disabled person for her wages. The worker doesn't always do the tasks right, perhaps because they don't need the job so much, or perhaps because they've become comfortable. They've got their feet under the table and they've slackened off. And of course, the disabled person is dependent on the worker to get them out of bed in the morning or to get them to work. And if the worker phones in sick, even the best relationship breaks down. So whether it's paid or unpaid, whether it's personal assistance or traditional care, the challenge is first to develop help without creating domination and infantilization, and second, for society to fund it properly. Intermediate bodies, mainly disabled people's organizations, can train both workers and employers to make personal assistants work for them. If you're in a remote or rural area, it's hard to find staff. You don't have as much choice. So, it's arguably you're not that much better off. You're still dependent. I think individualist cultures have to learn the importance of interdependence and community, as the pandemic has shown. But I think also interdependent cultures have to learn the importance of disability rights and everybody's desire for a measure of independence. We all have to learn. And I think this is a new area of inquiry. And so we are finding our way. So we need more research, which is where you come in. So I have some questions from you, which I'm really grateful for. What have you seen work well and not so well when it comes to evidence driving public policy in your research area? So here I wanted to mention two things. One is I was at the World Health Organization for 5 years. And they're there to create research and to translate research to assist governments knowing what to do. We wrote the World Report on Disability in 2011, which I would still argue was about as good as it gets in terms of global disability and public policy. More recently, I'm at the International Centre for Evidence in Disability, there's a clue in the title, and we have developed the Disability Evidence Portal. So if you search disability evidence, you'll find it, disabilityevidence.org. And what we've been trying to do is to do reviews of reviews. We take systematic reviews and we summarize them in a very short evidence brief. And we hope that that will be useful for policymakers in developing countries as well as perhaps in high-income countries. So we need to make evidence available. We need to make the research obviously relevant, but then we need to enable people to read it fast and give links so they can find the evidence that lies behind the brief. So what's the best method, you ask, for co-designing research with people with severe communication and physical disabilities? I think let's put disabled people in the driving seat, let them decide what matters to them, and then we try and design the research which answers those questions. We need to have much more co-production. Disabled people don't have to do the research, but they need to manage research if they can, if you can. It's not all research that has to be this, but it's worth a try. I'm doing some work with people with dementia at the moment, and we're writing papers together. I do the writing, they do the talking. They sometimes forget what they want to say, but between us, it's much better than it would be if I try to make it up without any understanding of what their lives are like. The CFI aspires to have lived experience at the heart of what it does. What do you think are the key skills and methodologies that researchers need? I think the ability to listen, coupled with honesty and patience. And people may take longer to tell their story, literally if they have aphasia, or they may forget what they were talking about, if they have dementia or whatever it might be. But if they learn to trust you, they will be your greatest allies and advocates. You're going to find out all sorts of stuff which you didn't know. And this relationship I have at the moment with people with dementia is really the most joyful experience of my research career. It's been fantastic. And I really look forward to our discussions. Question: how has your lived experience of disability most profoundly shaped your research? I'll give you a simple answer. So I was born in '66 and spent 40 years walking and not having any physical limitations apart from pain. And then in 2008, I became paralyzed, and I spent several months in a spinal injury rehabilitation unit learning to walk again. And this is where I learned how important it was to learn to stand, let alone walk again, how important physiotherapists were, nurses, nursing auxiliaries, occupational therapists, rehabilitation therapists, counsellors. I now think disability studies has to take into account rehabilitation because it's so important, not for all disabled people, but for so many disabled people in slowing loss, in restoring function, in enabling people to have the aids and adaptations to live a full life. Finally, your Dean of Research, my old friend Dr. Akili, says, we know from the social media your fondness for toppings on crumpets. What is the best Aussie crumpet topping you can recommend? Well, I know Australia has some great food and some real crimes against cuisine. Professor Arculi, I would imagine you could toast crumpets on a barbie. Once they're toasted, I just would add butter and Vegemite for an all-Australian triumph. So, g'day, it's been great to talk to you, and I hope your conference goes very well indeed. And I look forward to coming to Adelaide. I've been to Melbourne, I've been to Sydney, I've been to Brisbane, but I've never been to Adelaide, so I'm waiting for that invitation. Thank you very much for listening to me.